So welcome to Breakout Session C, your questions about inherited retinal disease with our Vision Quest chair, Dr. Ian MacDonald. This session is dedicated to your questions about inherited retinal diseases, whether you're newly diagnosed or you've been living with vision loss for many years. With that, you've all been introduced to our wonderful Vision Quest chair, Dr. Ian MacDonald, already. So I will invite him to come up and start with your questions. This is all about you today.
Thank you very much, Erin. And I'm going to write your questions down, too, so that I probably have some homework after today. So go ahead. You're on.
Thank you. I guess I'm kicking off the questions in every single room I've been in. So, but it's thank you for being here, Dr. MacDonald. The question I have is when someone's planning to have a family, and if they have RP, what are some of the considerations they need to think about? What are the sort of what information can they sort of obtain medically through testing that would help them avoid the chances of having children also with the condition or other types of eye conditions? What does a person need to think about when they're considering about being a parent?
Well, being a parent, you have to think about lots of things. But I must admit, I didn't plan my family. And I didn't quite mean it that way, but that's true. So number one arrived. And many of us marry within our own cultural group. We marry within our community because, you know, we're from a small town or even from a big town. And for some of us, we don't recognize that. And so there are different forms of retinal degeneration that are heritable, and they may be due to problems that are due to so-called dominant changes in the gene, where you have just one change and you can pass it on and it runs through every generation in a 50-50 fashion. And so that's one form of heritable vision loss. There's a so-called a sex-linked form where males only are affected and females are carriers in general. And then there's a recessive form, and that's why I was talking a little bit about, you know, small communities, marrying within your ethnic group, those sort of things. You might, by chance, marry somebody that you didn't know was also a carrier and have a child who's affected. And it's a common disorder called cystic fibrosis, where 1 in 20 of the general population is a carrier. And by chance, you know, you wouldn't necessarily know that, but and then you have a child that's affected. So looking at your own family history is important, knowing whether there are other family members affected or not. If there's no one else in the family affected, and you're the only one that's affected, and your wife isn't related to you, at least not to your knowledge, when I ask this question about, is your husband related to you, the wife usually says, of course not. I wonder what that means. But so when I'm asking really to find out what the family history is, I want to know if there's a pattern of inheritance in the family. And so there would be 4 things that I'm interested in: a dominant pattern of inheritance, a recessive pattern of inheritance, a sex-linked pattern of inheritance, and then possibly mitochondrial inheritance. Remember that there are genes that are programmed and are part of the nucleus, and then there's these little things called mitochondria that are in the cell, and they have DNA in them too. And they all come from your mother. And there are unusual disorders that are mitochondrially inherited. And so they tend to have a little bit of a different feature than just an eye disease. So we start with a family history and see what that's all about, and then go from there. And then I gather that you'd like to know a little bit more about, is genetic testing available? And yes, for certain conditions it is. Certainly, for a number of the X-linked forms of RP, there is genetic testing. For some of the more common dominant forms of RP, there is genetic testing available. For the recessive forms, it's a bit of a problem now, because there may be very many different genes that are involved. And so how do we pick out which gene it is? We have technologies called gene chips. They're not onion and vinegar or something like that. They're actually a glass slide with the DNA on it that's embedded, and it's a gene array, really. I don't know why people have used a chip, but it really isn't a chip. It isn't a microchip either. It's not an IBM chip. But we can use these to survey the genes that we know about and see if there are any mutations in those genes in your particular DNA, and then tell you, in some cases, not all cases, that this is the gene that you have changed in 2 copies. One of the difficulties then is, well, can you then test the partner and see if they're a carrier as well? And it's possible to do this, but of course it all takes time and money, and we're looking for a faster turnaround.
Hi, I have a further question along that line. So for testing, where you have a person that you know has RP, how about testing their children or grandchildren?
Right. Well, so for example, if you have an individual who has RP and you can test that individual and you can find the genetic change, we can go to other members of the family and make them aware that genetic testing is available, but of course consent needs to be involved as well. We can't necessarily test those individuals without their consent, so we have some issues in that regard. We have to very much follow a conventional approach and make sure that those individuals want to be tested, that they understand what it means if they're tested, if they're shown to be at risk or shown to be affected. For example, if it's, let's say it's a carrier of X-linked retinitis pigmentosa and they want to know whether they're a carrier or not, that's very important because it may have implications for whether they have children or not. They may make those decisions. I think it's very important to have counseling ahead of time, that it's clearly understood as to why you're undertaking the testing and what the implications might be of knowing what the result is. And in some cases that may not be obvious, and it may not be always apparent.
Okay, I just want to thank you for coming.
You're quite welcome, Paul. I'm happy to be here.
I just a follow-up question, because I actually recently had genetic testing. I have X-linked RP, as you know. I had genetic testing. They were testing for, I think, trying to find it on 2 specific genes.
Yes, that's right.
They were unsuccessful in finding it there. I was just wondering, so now that I've had genetic testing, I'm curious as to, and they weren't able to find something. I'm curious just to what your thoughts on like the future. Would I be eligible for future genetic testing? Is that something that's recommended, or I guess if you have any thoughts on those on the research surrounding X-linked RP and yeah, kind of where they're looking for those.
Right. So there's 2 aspects to genetic testing, and in some cases even the physician doesn't understand this, where the physician knows about genetic testing, that it might be available, and they recognize that there's a laboratory somewhere that can undertake that, can do that. And then that physician takes a sample from you, the patient, sends it off to the lab, and we don't hear anything about it. Both you as a patient and the physician thought that the lab was going to give you a result. But if it's just a research lab, they're under no obligation to provide any information. That's one thing that people tend to forget. But if you send it to a clinical laboratory, they're under the obligation to give you a result back, positive or negative. And there are different laboratories in the world that we link with, that we ask to do clinical testing. And if it's a clinical laboratory, they may do the test, and let's say we've asked for the RP2 and RP3 gene to be tested for X-linked RP, and no mutation is found. Well, we as in the healthcare system paid for that test, and we got a result. It was negative. It doesn't mean that they don't get paid. They still get paid, but it stops there. The clinical laboratory doesn't take it necessarily to the next step because they're simply receiving other samples. Some of these laboratories, though, have a research arm, and they may take that sample with your permission and then push that into their research arm and continue to work on that. But of course, in the consenting of research testing, it has to be upfront, because you wouldn't want to know that, oh gosh, you know, there was a laboratory that tested your sample and they sent it off to one of their pals and they found it. And then it came back that way. Maybe you wouldn't mind that, but you'd want to know about that beforehand. So coming all the way back to the question, it really depends on what laboratory the sample has been sent to initially, whether it goes on to the research testing. And in many cases, it continues to be tested. In my laboratory, I have an inventory of samples that I have the opportunity to retest where I haven't found a mutation, because there are new technologies that weren't available when the sample was first derived. So I would caution that you need to know beforehand what's going to happen to the sample. If it is in a research laboratory, it probably will continue to be tested. And just because they didn't find a mutation doesn't mean it can't be found. It's just a matter of when.
One question is on follow-up on his question, that who will recommend that we should give our samples for genetic testing?
So who would recommend it? So I think this is the conversation that is very important. So when you have the spectrum of disease as it is now, and there are future treatments or current treatments, and it is possible to undertake genetic testing based on the family, then I would offer it as a physician. But it's very much up to the family as to whether they would want to do that. And so we would offer it, and you would then suggest, well, yes, I'd really like to have testing done, and then we would follow through as best we can.
Means for that we should contact you?
Sure, absolutely, yeah. My genetic counselor as well works with me and follows up a little bit better than I have in past, and it's very important to have a team of individuals to help.
So will it be possible to talk to that person today? Yes,
absolutely.
Okay. My actual question was that you mentioned several eye-related diseases in the morning, LCA, Usher syndrome, Stargardt, Clorodon, which we are working. So are all these therapies currently on single gene mutations or more than one gene mutations?
Well, therein lies the complexity, that there are many genes and there are many changes in those genes as well. And many of those changes are what we call private to the family. They're not common. There are some common mutations that we can test for. It's interesting that there's a common mutation in a gene that encodes a complement factor, and that predisposes somebody towards age-related macular degeneration, and we can test for that. But in many cases, it's not a common mutation that we can easily test for. We have to get your DNA, find out what the gene is and then understand it more from that perspective. A little bit more complicated.
Hi. We went through the genetic testing process for my husband, and we now know the gene mutation. So once we get that information, then what? Like, what does it mean to us? What do we do? What do we look for? Is there somebody we can get in touch with to find out if there's more specific research going on? Just kind of like, where do we go from there?
Right. Well, And I think that's the magic of trying to translate this information, as I maybe use that word, translating the science. As a geneticist, I'm also interested in the heritability of traits and the understanding for the entire family that they understand what the risk is. In the past, I think people have been concerned that they weren't told about the risk of passing something on to their children, for example. And so there's that aspect of making sure that that there's an understanding of what that change in the gene really means. And I have the opportunity to work with a genetic counselor, Stephanie Chan, and she's been very instrumental in sitting down with families and speaking with them in depth about, now that we've found this change, what does that actually mean? And what do you understand that it means? It's fine for me to understand what it means, but how do you understand it? Do you understand it in the fashion that we would like you to understand it? So we engage in a counseling session as to what that genetic change means, what's the heritability of it, what is it going to be like, what do we know about the prognosis in that case, and then we try as best we can to know what treatments are available for that condition. There are, unfortunately, at the present time, few treatments, but they are emerging. And I think we mentioned very briefly, Aaron mentioned about the Foundation Fighting Blindness registry of patients. And so we would as well try to link you with that if you wanted, so that you would know that your information is there in the repository. And if there's somebody somewhere within the community who had a clinical trial that they wanted to recruit patients for a clinical trial, then you might be contacted. It's no good just having your name and address and telephone number in a file in my cabinet and then no one else know about it. So we have this registry. Your name isn't in the registry, but the actual genetic change may be there and your diagnosis be there, so that people can say, I'd like to find out if there are patients with a dominant form of retinitis pigmentosa, and because we have this new treatment and we'd like to know if this treatment works. So therein lies a little bit of that, and I will apologize for the length of time it's taken, I think, to get around to your family. That some things do take time, and the time frame when you have your blood drawn for cholesterol, it comes back in a week. When you have your blood drawn for a DNA test, it might come back in 6 months or a year, or whenever. And I think that's been very disappointing for the patient and the physician in some cases. And what can I say other than we're still working on it? So I can follow up as well with you about that.
Dr. MacDonald, about 2 years ago, I talked to you about getting testing for RP.
Right.
And the cost was approximately $350, $400, and with a 50-50 chance of getting some information. Have things changed and is the price come down, or is there more labs doing that kind of work?
The price is about right. It hasn't come down significantly. It is about $400 if one was to use a fairly broad-based approach. It really depends upon whether you have a dominant form of RP or a X-linked form of RP as to cost. For different genes to cost different, have different costs. If it's a recessive form of RP, the best first guess would be using a gene array to see if there's any changes. And then if we don't find any changes, well then it's hard to know how to apply technologies, because if there's just a single individual in the family, it's hard to know what to do. As well, we have to apply to out-of-province services here in Alberta for funding, and the key factor in having out-of-province services decide to fund a test, even a diagnostic test, is it isn't going to change management. And so I gave you the example of the young boy in Calgary. We knew that there was a possibility that it would change management, and it did. So there was an opportunity to apply for funding and get the testing done. So there's that dichotomy of access to services, trying to link you with genetic testing and have the government take on that $400 as a cost. It's not a lot of money, but if you're not sure it's going to give you the right result, then you're a little bit reticent about spending that $400. So cost hasn't come down very much at the present time. Costs for other things have come down, though. If we know what the mutation is in the family, gosh, we can do that for less than $100, even less than $50. But if you don't know the mutation, then it's very much a treasure hunt.
Hi, Dr. MacDonald. It's Peggy Johnson.
Oh, yes.
I wanted
Nice to
to
see you.
thank you again for all that you've done and helped me just come to terms with Stargardt's. A few years ago, we did some genetic testing. We sent away, I think it was to Estonia.
Right.
And would that be what you called, like you were speaking earlier, on your different research labs type thing? Would that be like the extended one that you send some of our, like some people's lab results to them to do the investigation into it further?
Well, so the one in Estonia is also called Asper Biotech. And so that laboratory uses a gene array, and it has all of the known mutations on their array. And it's in the range of about $400. But it only has the known mutations. And I'm aware that that laboratory, if it doesn't find the mutation using its array, then it will push it into their research laboratory and work on it when they have time. And they will work on that and see if they find a mutation, and if they don't, well, then they'll stop. But if they find a mutation, it's very important, because then they'll put it back on the array. And the array will become more and more and more comprehensive, so you won't miss things. But the Asper is under no obligation to report all of the things that it finds in that regard. So that there are some laboratories, the National Eye Institute iGene project, for example, that will receive, and the Carver Laboratory in Iowa, that will receive samples for Stargardt disease, and they will pretty much exhaust the avenues of trying to find out what the mutation is. So they will take an array-based approach, and they don't find anything, and then they will actually sequence the gene. So they'll take the gene and look at every coding sequence in the gene, one base at a time, over both copies of the gene, and say, okay, here it is. But that costs a lot of money. It costs about $3,000 US. That's just the disposables, and it's not the time that it would take to as well interpret the test. So very complex, and we would like to be able to offer all that, but you can imagine that it would exhaust the resources that we have and available to us. So we're hoping that some of these costs can come down.
Doctor, just scratching my head trying to understand and sort of grasp the problem. And I think we've talked about one thing before. It may be out of the realm of genetics, but it's linked to genetics, and that is, we're trying to decipher what basically the programming behind behind what causes the degeneration of these cells.
Right.
And I'm thinking to myself, I mean, we've talked about this before, I think briefly, but when you have, let's say, a non-working component in a machine, some machines, it's worth going in and trying to fix that one particular component.
Right.
Other times, you can sort of step away from the problem and replace a subsection of the machine. In other words, no, we're not going to necessarily operate on that one particular component. We're going to step away and look at the problem in a more holistic kind of look, expand the scope, and then, of course, fix that. And in turn, by fixing the bigger component, you in turn just fix the subcomponent, the smaller thing, right? And I'm thinking along those lines, and I'm also thinking along the lines of, like, I go back to it, male pattern baldness. Like, I'm thinking, okay, hair on the side of a man's head, right, doesn't go away typically, but the hair in the crown and the front does go away. And I'm putting all these together. I'm thinking to myself, is there a fundamental, like, is the fundamental pursuit in the details? Are we getting lost in the details?
No, I don't think we are.
Do you know where I'm going with the questions,
sure,
by the way?
I really do. At least I think I do. So for male pattern baldness, you can take the hair follicles from the back of the head and put it on the top of the head, and gosh, those hair follicles do really well. And I don't really know why male pattern baldness occurs as it does, but it does. And so for genetic diseases, you can imagine that you have a genetic disease, and there is the advent of stem cells, and we can make new stem cells, and new stem cells that might produce photoreceptors. But imagine it might not be in the best interest of the subject who's undergoing a stem cell therapy to just give back stem cells that have the same genetic disorder. We're going to have to change those in some way. And there's the magic, that we can make the stem cells, we can take skin, add 5 genes approximately, and create stem cells, but we're going to have to actually treat those stem cells. And hopefully those stem cells, that when they're provided to the eye, maybe underneath the retina, will regenerate photoreceptors that will have the proper gene in it that will function in that environment. So, so that's one thing. We've got to use some combination therapies here, and we're not there yet. We're there with the animals, but we're not there with. Well, Tanya would caution me here that I guess we're not really there yet. Let's keep it there. That there's lots of different steps that we'll have to take before we really understand how we're going to do that in a human. So now, two other very basic concepts. So you have a gene, and if you knock out the gene, you have no gene product. And there's no gene product available for the normal biochemistry, so you'll have to replace that in some fashion. And gene replacement is going to help. But then there's a whole category of disorders where you haven't really knocked out the gene, but the gene is still making a protein, but it's not the right protein. And that protein, that's exactly what you were talking about. It's gumming up the machinery. This protein is being formed, and it's not folded properly. It doesn't go to the right place in the cell. The cell gets disorganized, and then the cell, because the cell is supposed to survive for a set period of time, undergoes degeneration in a fashion that we are all quite aware of. So there's science that's ongoing as to how do we make that misfolded protein properly folded so it can function normally. And there are drugs called chaperones. Nice. I like that term, that just sort of hug that, shape it, make sure that it's bent in the right place like a chiropractor, and it's now functional. And that it's in the realm of pharmacology. But you have to really start with some basic understanding of genetics. How does it change a protein? How is that protein misfolded? How are you going to bypass that misfolded protein?
Hi, Dr. MacDonald.
Hi, Peter.
On the subject of your choroideremia gene therapy study, my question is along the lines of timelines. So let's say from now until the point where this treatment would become public to or available to the public. I guess I'm just curious, what do you view as kind of the major high-level milestones? And the second part to that would be, obviously, given the regulatory environment, it's probably difficult to answer, but what might you see as kind of the timelines for those milestones, assuming, let's say, a successful result at each of those stages?
So our major hurdle is Health Canada regulatory approval. We have to show them that there's preliminary safety information that would suggest that it's going to be safe in humans, and that we have experience either ourselves or elsewhere that there is sufficient safety and that there have been appropriate approvals received for gene therapy. And by that I mean that the Health Research Ethics Board has agreed that a protocol should go forward. They've looked at it and said that this is an experiment that they would agree to. We would also have to have approvals from the hospitals where we're going to do the therapy. So it's a surgical procedure. There would need to be a consent document that's agreed upon, and that the hospital is willing to the hospital and the university is willing to accept the risk. They would not obviously want to be in a situation where an experiment was conducted and there was significant risk and there was liability involved. They'd want to know that risks were agreed upon beforehand. So I would say that those steps are almost complete. We have ethics approval. We don't as yet have operational approval, so that needs to be occurring almost synchronously with Health Canada approval. So that our next big step is to go to Health Canada, which acts like the Food and Drug Administration in the United States, and think of this as a new drug that's never been used before. Health Canada wants to know, even though it may recognize that you are interested in having the therapy and that the researcher appears well placed to do the therapy, they want to know that all possible aspects have been considered. And we are waiting at the present time for some additional pieces of information on safety, because 6 individuals have already undergone therapy in the United Kingdom. And so we're hopeful. The United Kingdom is suggesting to us, that the information should be available and be sufficient that Health Canada would say, yes, this is fine. But I'm not Health Canada. I will say this, it was quite daunting to be told that it would be important to have a pre-meeting with Health Canada, and we would only require 1 3-inch binder of information. I thought, oh my goodness. So
Okay.
Go ahead.
I don't know much about the science of all this, and I just have a question about myself. My sister was diagnosed at 14 with RP, and my dad had been diagnosed long before. I was wondering for myself, is there an age where I can stop fearing that I'm going to develop RP? Or do I just have to keep going to the doctor and making sure I get checked out all the time?
It really depends upon looking at the other family members. So, for example, for me as a physician, I'd want to know what your sister was like. I'd want to know what her age was when she first showed symptoms. I'd want to examine her. I'd want to, if I couldn't do that, get information from her physicians, ophthalmologists, optometrists. I'd want to know, was your dad more severely affected than your sister? Could this be an X-linked form of retinitis pigmentosa, for example? And what the pattern of inheritance was. And then certainly there is the opportunity now to do genetic testing and sort of relieve that burden if we did find which gene was actually mutant in your family. And so that would be a huge burden to relieve. In the absence of that, there are some very sophisticated tests that we can do, including the electroretinogram. And if that, I know it's not a fun test to do, but there are some techniques that we can use. This is testing the retinal responses. We use a little, instead of using a huge thing that goes into your eye like a contact lens and with clips on either side, we use a little fiber electrode and do an electroretinogram and measure the responses of the retina and see how robust they are. And if your exam is normal, you have no symptoms, and the electroretinogram is normal, and maybe even we could do a field of vision test, that's a lot of information to say there's no impairment. And judging by your age, it would be, I would think, reassuring to suggest the likelihood is small that you would have inherited the same trait. But we have to sort of build that case in one way or another. And in some cases, just because you have the disorder doesn't necessarily mean that you're going to always look like your father or your sister. There's a bit of variability built into these things. Does that help marginally, or it doesn't necessarily fill all the blanks in?
I consider myself a lucky man because I had that test where they put that thing in my eye and shone this light after sitting in, I don't know how long, in darkness, and it showed that I have RP. But I can see perfectly.
Mm-hmm.
My grandfather had RP, my mother, my daughter. What can you say about the genes, my genes to my daughter's? Is there reason to compare them, or is there?
What you're really what you're really pointing out, rather, is the variability that exists. Mm-hmm. And I think the mistakes that I've made throughout my career are trying to give some idea as to what might happen. I'm very reticent to do that in terms of the expectation of what's it going to be like in 10 years. We know that on average for retinitis pigmentosa, there's about a 3% decline in function per year. That doesn't mean after 33 years there's nothing left. It just means that in year one, there's a certain amount, the next year there's 97%, and then in year two there'd be 3% less of 97%. So it's a very slow process. But there's a great deal of variability. And one eye may not be the same as the other eye in terms of the degree of affectation. And so trying to piece those puzzles together is challenging, and I think each individual family has to be approached in a different fashion. Can't necessarily apply the cookie cutter, this is what's going to happen. I was cautioned by one of my colleagues in Jacksonville, Florida, who you may know, and don't ask me why I've forgotten his name, but I've forgotten his name. He advised me quite clearly that only 2 to 3% of individuals with RP become totally blind, and that's an important figure to understand. That's a very important figure for the general public to understand as well.
Hello, Dr. MacDonald. You know that I have X-linked RP, and I just want to come back to a comment you made about potential stem cell therapies. And you're trying to achieve two things. So you could take a cell from my body and somehow, by some magic of science, turn it into a stem cell that would generate photoreceptors for my retina. But at the same time, you'd like to generate those photoreceptors so they don't have the defect, that the genetic code is properly configured. And I'm thinking to myself, why would a potential therapy care so much about the second step? Because if my photoreceptors provided useful vision for 20, 30, 40, or 50 years, depending on the patient, wouldn't it be useful to even generate those defective receptors again and get another 50 years? It's kind of like filling the tank in your car again for another 100 miles. So I just wanted your comment on that second step of the stem cell therapy regime.
Yeah, I really wish I could answer that. I really can't. And maybe I think Carol Sherman's having a session as well on stem cells. It would be important maybe to ask that question. I just have the understanding on a theoretical basis, nothing more. No, but thank you all for your questions. It's a challenging dialogue, and thank you for your patience. Some of you have waited a long time for your answers too, and I sense the pain and the embarrassment of the health profession, but we're getting there. And so thank you all for your questions. I enjoyed being with you.